I've been tasked today with speaking about venous compression syndromes and what are the indications for endovascular treatment and stenting. No relevant disclosures. So we've kind of come across this earlier today, venous compression syndromes. We've seen some examples of Thurner earlier in some of the presentations. I'm also going to talk about Paget-Schroetter and Nutcracker Syndrome. Thurner, so as we all know, refers to compression of the left common iliac vein by the right iliac artery. Along with the extrinsic compression, there is some theory that the chronic pulsatile flow within the right common iliac artery can result in some endothelial damage and cause local intimal hyperplasia. So in all of these patients, there may be some form of synechia, basically webs, bands, spurs within the vein that can exacerbate the venous stasis and further leading to symptoms for the patient. The presentation of the patient may be either post-thrombotic, so they might present to us with an acute iliocaval DVT, or it could be non-thrombotic, which usually refers to patients being symptomatic with unilateral leg edema, pain, chronic fatigue. Like I said, indications for management when they come to interventional, we'll see them either in the setting of acute iliofemoral DVT, with, basically when you end up doing catheter-directed lysis and venography, you identify the point of compression and then perform venoplasty and possibly stenting in some of these patients. The non-thrombotic, like I said, usually are symptomatic because of unilateral leg pain, edema, might develop varicosities, hyperpigmentation, venous stasis ulcers. And in these patients that are non-thrombotic, ideally you would do venography, venoplasty, and then consider stenting as well. So we've already seen this a little bit earlier. What is the ideal stent location? There's recent paper came out in 2018 talking about contralateral deep vein thrombosis post-iliac vein stenting when the stent extended into the IVC a little too much. Basically, the authors noted that there was venous intimal hyperplasia causing contralateral DVT, and what the ideal location for the stent could be, as we saw on the panel earlier today, basically should involve the affected area, but extend just a little bit beyond into the IVC, not jailing out the other vein. The other new trial coming out is the C-TRACK trial. This usually, this is going to deal with a subsect of patients that deal with post-thrombotic disease. So this is moderate to severe post-thrombotic disease. And essentially, this clinical trial is set to have the results published in 2023, and we'll see if venoplasty and stenting is indicated in this group of patients dealing with post-thrombotic syndrome. Next. So we're going to see a little bit later about the Venovo and the Vici stents, which are newly approved, FDA-approved stents for iliac obstructive disease. Next up, Paget-Schroetter Syndrome is the venous thoracic outlet syndrome. So usually this is young males in their 20s or 30s presenting with severe pain and swelling in the upper extremity as a result of DVT in their subclavian vein. The incidence is really low. Again, male predominance is noted in this condition. Because this is such a rare entity, there isn't really an established guideline or an algorithm, but most operators will agree that patients usually get referred for catheter-directed lysis, followed with surgical decompression. What type of surgery the patient gets is important for interventionalists to know, whether it's transaxillary approach or infraclavicular approach, and I'll talk about it a little later. If the symptoms recur, the patient will end up getting a repeat venogram, and if there is an area of stenosis or if there's a short segment stricture noted, then angioplasty and stenting may be indicated, and it does provide long-term patency of that segment. As you can see here in these images, you can see venography done post first rib resection. You can see that there is some residual stenosis within the vein, which has been basically resolved after stenting, and you have robust flow of contrast centrally. So Lee et al. Looked at data and saw that there was recurrent thrombosis seen in patients that received stents during initial thrombolysis, and that's important again for the interventionalist for when you're performing these procedures during catheter-directed lysis. It's important not to stent the affected lesion without making sure that there has been adequate surgical decompression. Again, repetitive trauma in the setting of chronic compression can lead to stent occlusion, fracture, fibrosis, and potentially limiting future surgical options for your patients. Stenting after transaxillary resection of the first rib has also been suggested to cause reocclusion due to inadequate decompression provided by the surgical approach, and that's why I basically said that you kind of need to know what surgical approach the patients had before you go in with the idea of performing angioplasty and or stenting. Nutcracker syndrome. This refers to compression of the left renal vein between the SMA and the aorta. So there is a less common form of Nutcracker syndrome, which is basically called the posterior Nutcracker syndrome, which refers to compression of the retroaortic left renal vein between the aorta and the vertebral body. So you may see this as just a retroaortic renal vein, or you could see it in a circumaortic renal vein, in which one of the renal veins goes posterior to the aorta and gets compressed between the vertebral body and the aorta. Here you can see some intraoperative pictures of, on the left here is just anterior Nutcracker syndrome, where you see dilatation of the renal vein just proximal to the point of compression, and then you can see the caliber change within the renal vein here. And on the right here, you can see that this is a retroaortic renal vein basically being compressed between the aorta and the vertebral bodies. So indications for treatment, these are usually young, healthy females in their 30s or 40s presenting with left flank pain and abdominal pain. A lot of these patients may present with unilateral hematuria, orthostatic proteinuria, and chronic fatigue. In males, this can present itself with left testicular pain or varicocele formation. Similarly, in females, they might have symptoms of pelvic congestion. Currently, the definitive treatment for this condition is still surgical decompression. However, endovascular approach has been shown to be safe and efficacious. Quevedo et al. Reported over 150 cases of successful endovascular stenting in anterior Nutcracker syndrome with resolution of the symptoms. Important takeaway with regards to stenting in Nutcracker patients is essentially that the distal end of the stent needs to be deployed within the first major branch of the left renal vein to achieve adequate fixation. It's important that you appropriately size the stent, and this may be achieved with IVUS before placement, so that you have accurate measurements of the left renal vein, and the stent is usually oversized by up to 20% to prevent any kind of migration. Ideal stent should have high radial strength and less shrinkage to allow for accurate placement. These patients get placed on anticoagulation for at least 6 months after the procedure, and midterm stent patency data is encouraging, but we need long-term data. Again, one of the complications with left renal vein stenting could include stent occlusion or intimal hyperplasia or proximal migration of thrombus and PE, and these have been seen. Here's a case from our lab, basically young patient with left renal vein compression. As you can see here on venography, you see that there is reflux of contrast within the gonadal vein post-stenting. Basically, we are seeing accurate stent placement covering the lesion and no reflux within the gonadal vein. And that's all. Thank you.